Welcome to the Jerry Powell Podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, who do we have with us today?
We are delighted to welcome back co-chairs of the AGS Beers Criteria Panel. First, we have Todd Semla, who's a clinical pharmacist and is at Northwestern University. Todd, welcome back to the Jerry Powell Podcast.
Great to be here. Thank you, Alex and Eric, for inviting us.
And we're delighted to welcome Mike Steinman, who's a geriatrician at UCSF and also a co-chair of the AGS Beers Criteria Panel and is co-director of the U.S. De-Prescribing Research Network. Welcome back, Mike.
Thank you.
So we're going to be talking about not an alternative to Beers Criteria, but alternative treatments to the medications that the Beers Criteria says we shouldn't put people on. Before we go into that topic, I think, who has the song request for Alex?
That was me.
Mike, what's the song request?
How about Getting Better by the Beatles?
Why did you choose this song other than Alex likes singing the Beatles?
Well, that was one reason. Two other reasons. First is that, the goal of the alternatives list is to help people get better, feel better, live longer, happier, and more productive lives. And then the second thing is, as clinicians and scientists, it's been a rough few months, and we can kind of hope for a note of optimism that things will get better as the months and years pass.
Love it. Here's a little bit. It's getting better all the time. I used to get mad at my school. The teachers that taught me weren't cool. You're holding me down, turning me round, filling me up with your rules. I have to admit it's getting better, a little better, all the time. I have to admit it's getting better, since you be mine. Beatles are fun. Thank you, Mike.
Right, you've got the education policy debates in there too.
Okay, so I'm going to start off with a case. We've got an 80-year-old patient who has a lot of medical problems, probably like many of the patients we care for. They have diabetes. They're on a sulfonylurea metformin. They have insomnia, which they take Ambien pretty much daily for. They have GERD, and they've been on a PPI for the last 3 years. They got lower back pain, and they're on pick your skeletal muscle relaxant that they're on, and PRN NSAIDs. They have neuropathic pain from their diabetes. They're on gabapentin. And then they have seasonal allergies, which they take some over-the-counter drug, which you're not 100% sure is, but you're pretty sure it's Benadryl. But they can't really tell you what they're taking. They just go to CVS and pick it up. Alex, any other ones that you want to throw out there? Does that sound pretty good?
You're covering it pretty well there.
I cover it pretty well.
I think they should be on Advil PM.
The Ambien's working pretty good. They love their Ambien, though.
I just wanted to make sure we had delirium in there.
Yeah. Okay. When you hear about this list as a leader in the Beers Criteria, what are you thinking? Well, before that, what is the Beers Criteria and how does it apply to this list?
So the Beers Criteria has been around since the 90s. Started out for nursing home patients about medications to avoid, not to use, or to use with extreme caution, particularly either by themselves or if the person has a comorbidity or condition that you could make worse by that medication. And for the past 12 or 15 years, the American Geriatrics Society has been responsible for updating it. And it applies not just to nursing home patients, but to all older adults, with the exception of palliative care, end-of-life situations. But it really looks at medications that we really should think twice about using, maybe avoid using them at all together. In older adults, also drugs that need to be adjusted for renal function that people may forget about, and drug-drug interactions that could happen to anybody, but in an older adult, they're more likely to cause morbidity or mortality. So they kind of rise to the top of the table. But the question's been, what do we do instead? That's what the people
if we're
wanna
going
know.
to say that we should have put somebody on this, and I would push you. I actually think this applies very much in the palliative care and hospice practice too, because some of the things that we're trying to avoid matter a ton in that population as far as maintaining cognition, deprescribing. So I love this alternative, even from this alternatives paper from a hospice and palliative care perspective as well.
And they're frequently used with the justification that, this is different at the end of life. Yeah. It's okay.
Yeah.
And maybe it's not as okay as some of our clinicians might have been trained to think.
Well, there's still a place for common sense.
Yeah. And it speaks to the larger issue that, the Beers criteria is one small slice of the larger landscape of drugs, and every drug has reasons where it might be used appropriately, and every drug has reasons where it might not be the best choice for an older adult or just an adult in general. And so kind of applying common sense and clinical decision-making throughout is going to be really important. Sort of thinking the Beers criteria is a starting point, but certainly not the ending point.
So it's potentially inappropriate medicines. You're not saying it's absolutely inappropriate medicines.
Yeah, exactly. Every drug in the Beers criteria might have a reasonable use in a given individual, and lots of drugs not on the Beers criteria might not be the best choice for your older adult for other reasons.
Yeah, I really liked in our last podcast with you, I think it was 2023 when you last updated the criteria, you said that these criteria should be like a stop sign. Like you come up to it and you pause, you stop, you come to a complete stop and you look around for alternatives. And maybe you go with one of the alternatives and maybe not. And maybe you continue on with that, but this should be a wait, check, hold on before we continue. Let's really think about this.
Yeah, and Alex, I've updated my analogy. I say that it's like you're driving down the street and there's a pothole, and you've got a choice. I can swerve and avoid the pothole, but I'm going to hit the person on the bicycle, or I can just go right over the pothole and hope for the best. So. The word avoid was kind of legacy language with the Beers criteria, but, you try to avoid the potholes.
Well, I'm not sure about that analogy because I don't think I want to hit the biker.
The stakes,
Todd does not like bicyclists, I think.
As a cyclist.
As a cyclist, stay away from Todd.
No, you don't want to hit the bicyclist, so you got to hit the pothole. You got to take the pothole.
These are your choices.
Always choose the bicyclist. I care about my car too much.
I kind of like the first analogy better.
Well, let's move away from cyclists. Alex has PTSD from car accidents in the past.
I'm not driving around Evanston, Illinois. Biking around Evanston anytime soon. Crossing that Chicago Century off my list.
Okay, alternatives. So we have this 80-year-old that we're seeing. They have diabetes, insomnia, GERD, lower back pain, neuropathic pain. They have all this stuff. I'm going to start off with insomnia. What's the pothole here? They're doing great. They love their Ambien. They feel great about it. You're coming up to the pothole. You see Alex to the side on his bike. What do you do here? What's the issue here?
Well, there are a lot of issues. So the first thing to keep in mind is this person is suffering because they have insomnia. So, our sort of foremost goal should be to help that person manage their insomnia and to do so in a way that's most likely to be effective and most likely to be safe. And the reason that there's a bunch of drugs on the Beers criteria that are commonly used to treat insomnia, which often cause more harm than good, is because those drugs either are sort of effective but cause a lot of harms, or maybe they're not very effective and they also cause harms. And so can we find a better both pharmacologic or non-pharmacologic alternative to help manage that patient's symptoms, which is the ultimate goal. The ultimate goal is not to start any specific drug or stop any specific drug, is to help the patient with the symptom and do so in a way that's safe and effective. So the different meds we might avoid, like in this case and others, include the benzodiazepines, include the Z drugs, which have
drugs like Zolpidem, the ones that starts with Z's, not for ZZ sleepy Z's.
Thank you. Exactly. Zolpidem, Zaloplan, Zopiclone, all the ones that are used to be.
Wow, that's impressive, Mike.
I know, really. And then, but also like, first generation antihistamines, your diphenhydramine, Benadryl, Advil PMs, tricyclic antidepressants like amitriptyline and barbiturates, which are used less commonly, but still, are used sometimes. So those are the meds that we say, most people don't use because they cause more harm than good. But there are a bunch of things that we can do instead.
What are the things that we can do? So this person's on Ambien. We're worried about, or Zolpidem. Sorry for using the trade name, but I'm using the trade name in a way you should take it off. Zolpidem. What should you do? What's the alternative here?
Well, it's important, and this is true for a lot of the different alternative criteria. It just goes back to basic principles of good medicine, which is before you treat the symptom, try to figure out what's causing the symptom in the first place and manage your therapy according to that. So the first step is to kind of evaluate that person for health conditions and factors that are contributing to their poor sleep. Is it the environment in which they're sleeping that's causing problems? Are they having pain that's contributing their sleep? Or nocturia? Are they having sleep apnea? Are they taking other medicines which are interrupting their sleep? So before we even start thinking about therapy, just think about like what's the actual cause and can we direct our treatment to the cause? Once you get past that and it kind of becomes more sort of, garden variety, sort of insomnia disorder without any obvious precipitant or other environmental factor you can fix, the first widely recommended treatment, which is recommended by pretty much all the clinical practice guidelines for sleep, is non-pharmacologic, which is cognitive behavioral therapy for insomnia. It's safe, it's effective, it is unambiguously first-line treatment for management of insomnia.
Is it easily available?
Yes.
Multiple delivery methods.
Exactly. So it can be hard to get, a trained CBTI sort of health psychologist or other trained provider. If you're in the VA, it's more accessible. If you're outside the VA, you might be more out of luck. But like Todd was saying, there's a bunch of different modalities. There's a lot of digital apps, website-based programs, which have been shown to be effective and can really be tremendously useful for people who don't have easy access to a trained therapist.
I have to say, because we just recorded a podcast with Victor Montori, who was really worried about the burden of care that we place on our patients outside of clinic. We're asking him to do more and more and more. And now he's really concerned about the digital burden. There's an app for that. Well, there's an app for everything. And they're all of different interfaces and you have different passwords and you got two-factor login. And it's a lot for our older adults who are complex conditions and are probably delirious from this list of medications that they're taking. And now you want them to start an app? I don't know. I hear him, and I worry about that. At the same time, I understand that there's a shortage of trained therapists. And the answer maybe shouldn't be always that there's an app. Maybe it should be we need more therapists. That's me. I'll get off my soapbox.
Well, but that's true. And that would be great. I ain't holding my breath until that happens. So the patient comes to me tomorrow, and insomnia tends to really bother people. Like it is not a small thing for most people, or many people at least. And so if
I still got to work tomorrow. I still got to do these things.
Yeah, if the framing is this symptom is really bothering you, we have a very effective, safe solution that's worked for a lot of people. It takes some work on your part, but it's worth it because it will really help you. If people have motivation to improve their symptom, that can go a long way. And a lot of these apps are designed for people who aren't super tech savvy. So totally hear what you're saying, but at the same time, we should be helping people help themselves. It's the same thing. You could say the same thing true for exercise. Like it's a pain in the ass to go out and exercise, several times a week. A lot of people don't like it. It's challenging, but it's worth it. So I don't think we should be shying away from encouraging a sort of self-help either.
Okay, so if you want to learn more about insomnia, we have an insomnia podcast we'll have links to in our show notes. But when would you consider pharmacological therapies, and what would the alternative be to the Z drugs or to the benzos?
So that gets to be a bit of a question. But the medications which may be safer, but not completely safe, because that doesn't exist, are things such as low-dose doxepin, and we're talking up to 6 milligrams per dose. It comes as a 3 and 6 milligram formulation capsule. The dual orexin receptor antagonists are another option, and Ramelteon. But we're also looking at short-term use for all these agents. They're not necessarily chronic medications.
All right, I'm going to dive quickly into each one of them. Again, this doesn't want to turn into an insomnia podcast, but I got to say, doxepin, isn't that a TCA, anticholinergic, antihistaminergic, a promiscuous drug as far as receptors are concerned? Medication, like promiscuous. It likes a lot of different receptors. Like, why doxepin?
Yeah, it's what we sometimes call a dirty drug. But we're talking about very low doses. We're talking 6 milligrams doses. Yeah. It's been studied in 2 studies in older adults and shown to be effective and safe. Where I think we get into trouble is when we have people trying to sort of cheat the system. And I fought this in the VA and I lost to try to get the 3 and 6 milligrams on formulary, but because people just want to use the 10. And they don't realize that the 10 is more than 3 times the 3.
And I heard, correct me if I'm wrong, Todd, I heard that its promiscuousness is only at the higher doses, but it's exceptionally good at just targeting the H1 receptors, histaminergic receptors at the very low doses. Is that right? Does that sound right?
That sounds right.
So not so anticholinergic at the low doses, maybe at the high doses, but at the low doses seems to work fairly well.
You see the same thing with mirtazapine, which is not one that really made the cut in terms of a recommended alternative. But it's, has its antihistaminic effects are at lower doses, but they get overridden by the alpha adrenergic effects at higher doses. So once you go above 30 milligrams per day, you're losing the sedating property of mirtazapine.
Yeah. And then it begs the question, well, why not trazodone? Why not melatonin? Why aren't those things that Todd?
Yeah, why not melatonin? You gotta
right. Or trazodone, which are probably far more prescribed.
Rameltion, that's basically the pharma version of melatonin, right?
Right. And the difference is evidence. There's just really limited evidence for a lot of these things, including for trazodone, low-dose mirtazapine, melatonin, other drugs of that ilk. There's just really limited evidence. It doesn't mean they absolutely don't work.
Yeah.
But we don't have much evidence that they do work. And particularly for melatonin, the evidence does not suggest it's not super effective. They're probably reasonably safe, but not going to help people so much except through maybe placebo effect for sort of, just general insomnia disorder. We're not talking about more sort of specialized forms of insomnia. Go ahead, Todd.
I think this gets back to the methodology of how we did the alternatives, which we haven't really talked about yet. So we didn't look for the primary evidence because we have a hard enough time with the Beers criteria finding primary evidence to support what we're doing. It's mostly observational cohort type studies. But, to go out and find clinical trials for the alternatives that show that they're in older adults is pretty rare.
Yeah.
So what we ended up, our subgroups, our panel ended up doing is looking at what are the recommendations from other societies and other clinical practice guidelines. And specifically, we're hoping to find those recommended for older adults. So when we start looking at through the sleep recommendations, this is what other organizations and sleep guidelines were recommending.
And is it possible, I know we don't want to turn it into an insomnia podcast. We got a lot of other topics we want to get to. And is it possible that some of those society guidelines were influenced by pharmaceutical industry conflicts of interest?
Yes, for sure. It's true for any guideline for members sort of have conflicts of interest. Many of them. So
the Beers criteria alternative list?
We do have a series of disclosures. Most of our panelists do not have any conflicts to disclose. Some do. They tend to not directly be from drug manufacturers. But make your own judgment based on the disclosures.
Yeah. I got another question. Real quick, insomnia. If you had somebody insomnia in the hospital, you try to do all those things you can to avoid the insomnia, us waking them up, all of that. You're probably not going to be doing CBTI in them in the hospital. Like, is there a drug that you would use in this alternative list for them? Todd, are you thinking doxepin here? Low dose, 3 milligrams?
If you can get it.
Yeah, if you can get it. That's the issue.
Yeah.
Yeah.
You could also be looking at a dual orexin receptor antagonist, one of those agents as well, as another possibility. The evidence from the clinical trials, the effect on sleep latency and sleep length is pretty small compared to placebo, but it may work well enough in those situations.
So I'm going to refer all of our guests to the Insomnia podcast. We'll talk more about that in the Insomnia podcast. But I want to get into this 80-year-old again. I think we've talked about his insomnia. Mike said, "Oh, you want to make sure that nothing else is bothering during their sleep. Good history and exam." And they say, "Yeah, it's my pain. I got this neuropathic pain in my feet. I take gabapentin for. I got lower back pain. I'm taking Flexeril or cyclobenzaprine for." And they're I don't know if they're really working. They say, "Where are we now? We're seeing more potholes now." Alex is still next to us biking. Who wants to take that one?
I can maybe start. Pain's really easy. We all have the easy solution.
Yeah, you tell us not to use anything.
Exactly. I know the exact answer. I'm just going to not tell you.
Avoid skeletal muscle relaxants.
I mean,
you
it's
kind of avoid gabapentin.
Right.
NSAIDs.
Right. So, I mean, first thing, is setting realistic expectations about what you realistically can and can't do, and kind of helping to, as palliative care experts, I'm not telling you anything you haven't taught me, 10 times over, focus on, understanding what's a reasonable outcome for the pain, focusing on functional outcomes rather than expecting your pain's going to get to zero. But, once you get beyond that, it gets back to what we were talking about before about insomnia. It's like, let's see if there are underlying triggers of pain that we can address. Probably not the only thing that we need to do, but at least it's a good start. So looking at those environmental, other kind of contextual factors, other drugs, other conditions, lifestyle modifications, things like that can help with that pain. And then the other thing is there are other kind of non-pharmacologic therapies. Pain, of course, it's a lot of it lives in the head. It's how we process pain, how emotional reaction to pain. How
it's all in the head, right? You don't have a head, you don't have pain. You have no exactly. Fibers going up, but pain is an experience.
Right. So what can we do with the non-pharmacologic therapies that kind of help with these sort of our the way our brain processes pain? Yeah. So education intervention, exercise, and this is all evidence-based stuff from the guidelines. Like Todd said, we didn't try to reinvent the wheel by reviewing every single primary evidence. We went back to the guidelines and saw what the guidelines said, and so some effective things that tend to work across a variety of causes of different types of pain. Education, exercise therapy of different types, aerobic, aquatic, strengthening, yoga, physical therapy, cognitive behavioral therapy, and then some other kind of non-pharmacologic, medical interventions like peripheral electric or magnetic stimulation, acupuncture, things like that. And so those are things we should be thinking about rather than saying, okay, here we have a bad drug. Let's take off the bad drug. Let's find a better drug to put in place of the bad drug.
That's we not as bad, but still has that way.
Yeah. Go back to first principles. We very well might need another drug, but that shouldn't be our first reflex.
Yeah. Mm-hmm. So for lower back pain, there's a lot of non-pharmacological interventions that we can do to manage lower back pain.
Exactly.
Mm-hmm. And depending on the cause of the lower back pain too.
Right. And one other thing to kind of keep in mind is that, I think the Beers Criteria and other sort of guidance in older adults has sometimes led to an irrational fear of NSAIDs. Yeah. Like guidance in the AGS Beers Criteria basically says, don't use NSAIDs regularly for more than a month. If someone needs to take NSAIDs every once in a while, to manage their pain, and it works, that's a pretty safe regimen. And if it works for you, it's effective for you, then by all means. So it's not like we should never use NSAIDs. Yeah. We just be cautious about using them regularly for long term.
And maybe be careful which NSAID you use.
Exactly.
Yeah? How so?
Well, you just don't want to use ones that are more likely to cause ulcerogenic problems. So maybe stick with a COX-2 inhibitor, which is less likely, or if you need to put somebody on some type of gastroprotective regimen, like an histamine antagonist, or even a PPI for short-term use, that's okay.
Mm-hmm. Okay, where are we with the COX-2 inhibitors? Was that a decade ago? Weren't they bad?
I feel like that was 15 years
ago.
You're dating yourself there. Well, the ones that were the highest risk are off the market.
Vioxx?
Yeah.
I mean, so celecoxib is, has a has less specific affinity for the COX-1 receptor, so it tends to have less of the problems that you got from a drug like Rifaximin Provix that had more affinity. I think my understanding is that the evidence of harm, benefits are generally similar between sort of COX-2 inhibitors and NSAIDs. And then the harms, if you take a gastroprotective agent, they're generally similar between the NSAIDs and the COX-2 inhibitors. So sort of, which are still in the market. So take your pick. Yeah. As long as you avoid stuff like indomethacin, which is particularly risky.
All right.
And don't forget we have another delivery system for NSAIDs, and that's through the topical. So depending on, is this the right knee that's bothering this individual, and can you localize that treatment? And there are other topical agents that may also be helpful when the pain is lessened. Maybe you need the NSAID, oral NSAIDs for flare-ups.
Yeah. Or if this person has diabetic neuropathy in bilateral legs, capsaicin, lidocaine, combo like lidocaine, capsaicin.
They're all pretty safe as long as you don't put it in your eye or open wound,
Yeah.
Worth a try.
Yeah. I got a question though. So this person is on a PPI for the last 3 years for a history of GERD. So we're safe, right? But I think PPI is maybe on the beers list too. Are they?
They are.
What are they on the beers list for? Because everybody's on them.
Well, they're on them specifically for things like GERD, in particular. For chronic conditions like Barrett's esophagitis and other things, we don't refer to them in the Beers criteria. We recognize that they have a role there. But we're really trying to avoid them because of the long-term safety issues that can occur with these agents. It sets people up for C. difficile infections, perhaps pneumonia. What else am I missing, Mike?
I think atypical femur fractures.
Yeah. So those types of side effects.
Yeah, so we want them off it. I also saw, though, that H2 blockers maybe as a short-term relief at night. Aren't H2 blockers not so great too, or where do they fall into this?
They're really more restricted in patients who have at risk or have a delirium. That's what we're more concerned with those agents.
Okay. So maybe if we're using NSAIDs, we decide to use NSAIDs, Mike, we could also consider a PPI for GI protection. But if it's just GERD.
Yeah, if you look at the guidelines for sort of uncomplicated GERD, it's basically treat for a PPI for 8 weeks and then stop. Like the guidelines do not say to continue forever because a lot of times your GERD symptoms will resolve or at least dramatically improve, and then you can use your either PPI at an as-needed basis, even though there's some sort of pathophysiologic theory it doesn't work. It seems like for some people it does work, or just better yet, use an H2 blocker or an antacid or something as needed. So if someone, got started on a PPI 3 years ago because someone thought they were having GERD, and then they just kind of never stopped it, and they don't have an indication, they're not taking a chronic NSAID, they don't have Barrett's esophagus, they're not taking a chronic steroid, don't have a strong indication to keep using it, help to, don't stop it abruptly, help to maybe wean that patient off of it. And there are guidelines about how to wean PPIs and other commonly used meds.
Do you have a good place for those guidelines? Is this deprescribing.org or where are those guidelines? Deprescribing.org?
Deprescribing.org from our arch nemesis, Canada.
Is their guidelines tariffed now?
Yeah.
Good news.
Well, you have to pay 100% tariff, but 100%
tariff on a free thing is still free. So that's good.
Yeah. No, and those guidelines are super helpful because they're very thoughtfully constructed, they're evidence-based, and they're simple to use. They have these very simple to use kind of cheat sheet algorithms where you can just follow the algorithm down. It tells you when to deprescribe, how to do so safely and effectively, what to look out for. And it's the kind of thing you can look at in 10 seconds and kind of know what to do and have information you can give to patients. So strongly recommended, deprescribing.org. And they have them for a series of different
meds. And we'll have links to that site plus our Deep Prescribing podcast with them on the show notes. Go ahead, Alex.
Okay, well, so one question that came up at the AGS session that you did, which was terrific, and we'll include a link to it in our show notes, was one of the participants asked about the use of cannabinoids which could be used for a variety of the topics that we're discussing today, including, say, pain, insomnia, for example. Thoughts about and why weren't cannabinoids on the alternatives list?
Well, we know that our pain group looked at that as alternatives for pain, but they couldn't find anything in recommendations because the evidence really isn't there. And it also goes back to when we talked about melatonin earlier. One of the concerns we have is the quality of products, is what's in the product, which on the label, really what's in the product.
Yeah.
And there's unless it's got like a USP seal on it, you really don't know. And I don't think the USP has been certifying cannabinoid products, at least not to my knowledge yet. And which cannabinoids, what ratio of THC to CBD do we need?
Yeah.
That's also kind of under investigation right now.
Mm-hmm. And we'll have a link to our cannabis podcast. I think that was within the last year or so.
And it's not available in all states.
Mm-hmm.
CBD even.
Yeah. I got another question. This 80-year-old, has been on metformin and the sulfonylurea for the last 20 years. Doing really well with that per him. A1C is fantastic, 6.5. Is this a pothole? Mike?
Potential pothole, sure.
Oh, why?
Yeah. Well, this kind of goes back to the original Beers criteria where I would present at grand rounds or something, and everybody would say, well, I've got patients that have been on these drugs for years and they've never had a problem. Well, you haven't come up to the mile of road where that pothole is living, just waiting for you.
Yeah.
So that's what you're worried about. Is this patient at some point going to start to develop hypoglycemia? Maybe they stop eating regularly, or they get ill and they develop hypoglycemia or something. So it's a concern we have long term. Also, a hemoglobin A1C of 60.5 in an 80-year-old, that's pretty low. I mean, what would it be like if they were just on metformin? I'd be curious to know.
Yeah. 6.8.
Yeah. and what's the risk of hypoglycemia then?
Yeah.
So it sounds like you're worried not about the metformin in this case. You're worried about the sulfonylurea, which is on the Beers criteria, right?
Correct.
Yeah, so it's on the Beers criteria as a medicine to avoid as first or second line treatment.
Okay,
And
so it's
because of
not.
risk
So you
of
never use a sulfonylurea. There are certain indications that you may want to consider it, but because of the risk for hypoglycemia, but it has a super long track record. Like, we know the risks and benefits of this drug versus some of the newer agents. We're just kind of figuring them out.
Right. Well, we also recognize, because this came up when we released the current edition of the Beers criteria, people were really concerned that's what their patients can afford, and if they need a second line agent, or they can't take metformin, this is what they can afford, and we recognize that, and that's part of your decision as to whether you hit Alex on the bike or you hit the pothole.
Right. So it's always Alex.
Poor cyclist.
Easy choice.
And then the other thing to keep in mind, and this is true for all these drugs, right? It's got to be a process of shared decision making. It's not like I, the clinician, am going to unilaterally stop the drug whether you like it or not. We're going to burn bridges that way. So, there's a whole literature and sort of area of expertise around how to have these deprescribing conversations. But we need to be really thoughtful for all these things. Like the framing needs to be like, we want to help you. We want to manage your symptoms. We want to help you live longer, happier, better. And that is my goal. And this is why I would make this recommendation. It's going to help you meet that goal. And if the patient doesn't buy in, then it might be best to come back to another day.
Shoot. I looked at the wrong patient's chart. Even when I see it's not 6.5, it's 8.4. And they've been having some hypoglycemic episodes. Is there an alternative? Should I just put them on insulin and call it a day? How should I think about this?
Well, first thing is like, what's their dose of metformin? Can that be raised? If they're having hypoglycemic episodes, that certainly ups the ante to kind of be more aggressive about stopping the sulfonylurea. Yeah. And then, you mentioned like there are newer therapies, but even though they're newer, some of them are not especially new. A lot of them have been around for at least a while now, and others have had a few years of experience. Yeah. They seem to be pretty safe and effective in older adults. I'm talking, the DPP-4s, the GLP-1 receptor agonists, the SGLT2 inhibitors. And so all those have a much more robust, track record of safety and effectiveness than sulfonylureas at this point. So there are cost issues for sure, which are real and serious. But at the same time, can we find a way to get a patient if their A1C really is above target, and after thoughtful consideration of what that target should be, then I would definitely sort of see if we can, maybe substitute in one of those medicines instead.
How do you choose between? Do you have any quick advice? How do you choose between that for the GLP-1s, SGLT2s? Like, how do you?
It's complicated. I could say
it's a long talk.
Long talk. Comorbidities. Some of these ones are better for CKD or heart failure or other conditions than others. So we look at guidelines.
Okay. So look at guidelines. Okay. So you decide to put this person on they switch to a GLP. They're doing well over the next 2 years. And then palliative care gets consulted for significant weight loss and wondering, hey, can we put this person on megestrol for their continued weight loss because it seems like they're getting more frail and they're losing weight. This is actually, I've heard this happening to someone. Palliative care getting consulted for weight loss and somebody on a Ozempic. Thoughts, Todd?
Well, first of all, megestrol is on the Beers criteria because it's associated with increased mortality in older adults. Something we try to avoid. So I guess the question would be, do they still need their Ozempic or whatever they were on? Is this the reason why they've lost so much weight, or they need a further workup?
Yeah.
There's all sorts of non-pharmacologic interventions that we want to look at. Are they having difficulty preparing their meals or shopping for food? I once had a patient who we're trying to get her to increase her calcium intake, but she avoided the dairy aisle because it was too cold. So look for things like that.
Yeah.
So hypothetically different case than when we're thinking about appetite stimulants. Is there one that's not on the Beers criteria that we could potentially choose? Or is this just all non-pharmacological, like look at other causes for their decreased PO intake or loss of appetite? Is there anything on that list, on the alternative list?
Well, some people would say if the person has depression, that you might want to try mirtazapine as something to stimulate their appetite. I don't recall that. It's like the only thing the person didn't have.
Yeah, they did not have depression. Yeah,
and we know that mirtazapine isn't really our sleep alternative, but some people might still say, well.
So no evidence for sleep or appetite outside of depression, but if they're depression, maybe it's a good drug to use from a side effect profile. Is that a good summary?
Yeah.
Yes.
Yeah.
All right.
Anything else?
I'm not aware of other medications. Most of our other alternatives are all from the farm.
Cannabinoid. I guess we already talked about the cannabinoids. Marinol. Honestly, I've never seen somebody get better on Marinol for appetite. That sound about right?
Yep.
Yeah, it's certainly not in sort of evidence-based guidelines for weight loss.
Alex, any other palliative care symptoms coming up that
behavioral symptoms in this a different case? I don't know that we could do everything in the one case. Behavioral symptoms for people with dementia. Thoughts, recommendations, like the geriatricians will say, of course you're going to say non-pharmacologic first. And they'll say, we've tried that, we tried that.
Geriatricians and their non-pharmacologic.
Come on.
Give me something.
Yeah, give me something.
Yeah, well, I mean, the other thing to think about is not just like, did you use get into the person's world and try to redirect, but also are they having other clinical conditions which are going, this is getting back to first principles, things which are causing them to be agitated in the first place. Are they constipated? Are they in pain? Are they having urinary retention? Something else going on. So kind of making sure we're ruling that stuff out. There is a role for antipsychotics in the management of agitation or aggression in people with dementia. If the person's at risk for themselves or others, and the non-pharmacologic stuff has failed. So it's not like you should never use it, but it's again going back to, I don't want to use the swerving to Alex analogy.
Severe distressing hallucinations.
Yeah, exactly.
Give it a try.
So but there's a risk. I mean, they increase mortality. So we should be thinking about all the things that are safer and we know to be effective. But if those aren't working and the person is desperate for therapy and they're willing to take those risks, then it can be a reasonable thing to do. We're recognizing that, some of them have been FDA approved for treatment of this and others have not. It doesn't necessarily mean the others are ineffective, but it just means there's maybe more evidence for, like, say, brexpiprazole compared to some of the others.
All right, I got my last question for you. You've both been dealing with Beers Criteria for so long. What is your pet peeve? Like, what's like if that drug on the Beers Criteria that I hate that drug. And there's this other alternative that you think is great. Do you have one? Mike, do you have one?
I don't have a single drug. I think the thing I hate most is like just people take an overly simplistic approach to it. Like, there's a list of bad drugs, we should never use them, and everything else is fine, which is just not true. And so, like, applying clinical judgment and just applying good clinical common sense to how we think of these lists, and just going back to first principles, like figure out what's causing the symptom. Let's see if we can try a non-pharmacologic strategy. Like, this is not rocket science, but, as clinicians, we're often so busy and overwhelmed, we kind of often skip past that stuff. So the thing I always try to remind myself, easier said than done, is just take a step back and let's just go back to first principles before I just sort of act reflexively on any of these lists.
All right, Todd, do you have one?
Yeah, it's similar to what Mike's saying. I think that people overinterpret or oversimplify the criteria. And they see a void and they don't read the recommendation, they don't read the rationale and apply that. So avoid means avoid at all costs. And sometimes that comes down to third-party payers and others. But, you never want to hit the bicyclist. I'm just going to close with that.
Thank you. Thank you.
I want to be clear about that.
But what if you have a really nice car?
Alex has got a nice
Cars can be
bike.
fixed. We want to keep Alex in one piece.
All right, Alex, you can sing more now. You're not going to get hit.
I used to be angry young man, me hiding me head in the sand. You gave me the word, I finally heard, I'm doing the best that I can. I've got to admit, it's getting better. It's getting better all the time. I have to admit, it's getting better. It's getting better since you'll be mine.
Wonderful. Mike, Todd, where can we find this article that you published?
As of this moment, it will imminently be published in the Journal of the American Geriatric Society. And also should be links from the American Geriatric Society website, americangeriatrics.org.
And there will be a link from the GeriPal website. So take a look at that. Todd, Mike, thanks for joining us on this GeriPal podcast.
Thank you for having us.
Thank you.
And thank you to all of our listeners for your continued support. We'd also like to say a big thank you to those who've donated more than $250 to the GeriPal podcast over the last year, including
Anna Lynch, Deborah and Jeffrey Larson, Krista Mossack, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones, Kate Mesrich, Jen Hopping, Ashad Abid, Michael Bordowski, Asher Edwards, Susan Nelson, Harry Hahn, Carol Heyman, Gretchen Schwarzy, Sharon Brangman, Elizabeth Chung, Paul Amatelli, Brian Castle, Victoria Braun, Susan and John McFadden, Christopher Heck, Emise Samoji, Matthew Schuster, Carrie Hagan, and Lloyd Woolstadt.
a very big thank you. And if you too want to donate to the GeriPal podcast, please go to the GeriPal website and click on the blue or orange donate button.